Clinical chemistry, disorders of carbohydrate metabolism. Hypoglycemia, or not enough glucose, hypo means less, glycemia is talking about your blood glucose, is difficult to define the lower limit. A transient decline may occur 1.5 to 2 hours after a meal, and concentrations as low as 50 mg per deciliter may be observed 2 hours after ingestion of an oral glucose load. Symptoms vary and none are specific. Trembling, sweating, nausea, rapid pulse, lightheadedness, hunger, epigastric discomfort. The epigastric region, if you remember the 9 abdominal regions, that's the upper middle region. CNS symptoms are present when levels are less than 20 to 30 mg per deciliter. Neuroglycopenia include headache, confusion, blurred vision, dizziness, and more severe consequences include seizures or loss of consciousness, even death. Neonatal glucose is lower than adults. The mean is 35 mg per deciliter. It declines shortly after birth due to the depletion of liver glycogen stores. Levels as low as 20 mg per deciliter can occur without clinical signs. Common causes of hypoglycemia are transient, so prematurity, maternal diabetes, gestational diabetes, maternal toxemia. Onset in early infancy, so inborn errors of metabolism. Ketotic hypoglycemia, which typically follows fasting or febrile illness. Adult hypoglycemia, symptoms that are suggestive of hypoglycemia are common, but hypoglycemia is rare. True hypoglycemia usually indicates serious underlying illness and may be life-threatening. Symptoms usually begin at plasma glucose levels of less than 55 mg per deciliter and impaired CNS function at less than 50 mg per deciliter. It may be due to a decreased hepatic synthesis of glucose or increased glucose utilization. There's over 100 causes. Some of the causes are listed below, include drugs, which is the most prevalent, ethanol or alcohol, liver failure, insulin-producing pancreatic tumors or non-pancreatic tumors, septicemia, and renal failure. Postprandial hypoglycemia, typically induced by drugs, antibodies to insulin or insulin receptor, or inborn errors of metabolism. Reactive hypoglycemia is functional hypoglycemia. Idiopathic, which means without a known cause, clinical disorder with postprandial symptoms occurring in everyday life accompanied by blood glucose of less than 45 to 50 mg per deciliter. Symptoms occur 1 to 3 hours after a meal. So postprandial is talking about after you eat something. So symptoms are going to start 1 to 3 hours after a meal. It's an infrequent disorder and the demonstration of hypoglycemia with concurrent symptoms. Whipple's triad includes low blood glucose, typical symptoms, alleviated by glucose administration. Normal blood glucose at the time of symptoms excludes hypoglycemia. Diabetes mellitus is a group of metabolic disorders of carbohydrate metabolism in which glucose is underutilized, leading to hyperglycemia. So here is a chart showing normal and diabetic plasma glucose levels. 10.2 million diagnosed cases, perhaps as high as 15 million during the same time. The prevalence increases with age. There is a racial predilection. By 65 years of age, 33% of Hispanics, 25% of blacks, and 17% of whites are diabetic. It's estimated to cause 150,000 deaths annually. There's type 1, type 2 diabetes, and then there's gestational diabetes and other types of diabetes. So type 1 is an autoimmune destruction of the beta cells of the pancreas. Type 2, beta cell failure and insulin resistance. Other types include genetic defects of the beta cells, rare insulin resistance syndromes, and so forth. You can kind of read through the list here. And then gestational diabetes is any degree of glucose intolerance that's diagnosed in pregnancy. So comparing type 1 versus type 2 diabetes mellitus, type 1, the onset is usually below 20 years of age, while type 2, it's usually over 40 years of age. Insulin synthesis is absent because there's immune destruction of beta cells in type 1 diabetes. In type 2, insulin is still produced, so insulin synthesis is preserved. It's a combination of impaired beta cell function and insulin. Plasma insulin concentration in type 1 is low or absent. In type 2, it's low, normal, or high. Genetic susceptibility, yes, inheritance is associated with HLA antigens in type 1, and in type 2, it's not associated with HLA, but it is important polygenic inheritance. Islet cells, antibodies at diagnosis, yes for type 1, no for type 2. Obesity is uncommon in type 1, but it is very common in type 2. And ketoacidosis, yes, in type 1. In type 2, it's possible after major stress. So type 1 diabetes mellitus it results from cell-mediated autoimmune destruction of pancreatic beta cells. Loss of 80 to 90% of beta cells is necessary for diabetes. Alpha, delta, and other islet cells are preserved. Chronic inflammation of the islets, production of autoantibodies. It has a complex genetic inheritance, and there's various environmental factors involved as well, certain viruses, chemicals, and even cow's milk. Type 2 diabetes mellitus, there are two pathological defects. One is the decreased ability of insulin to act on the tissues, so insulin resistance or primary underlying defect. And then there's also beta cell dysfunction, the inability to produce enough insulin to compensate for the insulin resistance. Hyperglycemia renders beta cells increasingly resistant to glucose, glucotoxicity. Selective glucose unresponsiveness, the loss of glucose-induced insulin resistance or release. And then another cause is the results from combination of genetic and environmental factors. So nearly 100% concordance with identical twins. Racial differences, Hispanic Americans, Native Americans, African Americans, Asian Americans, and Pacific Islanders. Diet and exercise are important factors. 60 to 80% of individuals with type 2 diabetes are obese. Fewer than 15% of individuals will develop type 2 diabetes. Insulin resistance is decreased biological response to normal circulating insulin. Obesity is a major predisposing factor for non-diabetic individuals, and then type 2 diabetes. Manifestations are cardiovascular disease, hypertension, polycystic ovary syndrome, non-alcoholic steatohepatitis or non-alcoholic fatty liver disease, and metabolic syndrome. Diagnosis is insulin is challenging to interpret, fasting in response to glucose, C-peptide. So insulin resistance and inadequate insulin response leads to type 2 diabetes, which can cause retinopathy, neuropathy, nephropathy, neuropathy. So retinopathy is talking about disease of the retina. Nephropathy is talking about diseases of the nephron tubules of the kidneys. Neuropathy is talking about diseases associated with neurons. CVD, cardiovascular disease. Then we have compensatory hyperinsulinemia, insulin resistance syndrome, which can cause hypertension, stroke, PCOS, and NAFLD. Non-alcoholic fatty liver disease. The sites of insulin resistance, it can happen at the pre-receptor, but this is rare, where insulin receptor antibodies are produced and there's an abnormal molecule. At the receptor, you have a decreased number or affinity of insulin receptors. This is not important in diabetes. Post-receptor, defects in signal transduction after the glucose is bound to the receptor. It's the most probable site of insulin resistance in diabetes. The insulin is bound to the receptor. Most probable site of insulin resistance in diabetes. And then glucose transport. Deficient or defective glucose transporters. This has yet to be established. Some long-term consequences of diabetes: retinopathy, visual impairments and blindness, macroangiopathy, so coronary heart disease, peripheral vascular disease, nephropathy or renal failure, diabetic foot, peripheral neuropathy, and ischemia causes foot ulcers, may lead to amputations, and autonomic neuropathy, diarrhea and impotence. The assessment of a diabetic patient is based on blood glucose and HbA1c, an eye examination, serum creatinine, urine production, microalbuminuria, neurologic examination, ECG, and serum lipid levels. Gestational diabetes. Transient glucose intolerance occurring during pregnancy. It develops in 4% of all pregnancies in the United States. 40% go on to develop type 2 diabetes later on in life. You screen for gestational diabetes between weeks 24 to 28 for those at high risk. Risk factors include age 25 and over, less than age 25 and obese, history of diabetes in first degree relative, or belonging to ethnic or racial group with high prevalence of diabetes. Complications of gestational diabetes include perinatal morbidity and mortality, an increased rate of cesarean delivery, and chronic hypertension.